Personality disorders. Case study for personality disorders from S. Nolan, Hoexima, Abnormal Psychology for that /E, page 440 to 441. At the initial meeting, Cindy was a 30-year-old married woman with no children who was living in a middle-class suburban area with her husband. She had a college education and had finished almost 2 years of medical school. Cindy was referred by her psychiatrist of 1.5 years, who was no longer willing to provide more than pharmacotherapy following a recent hospitalization for a near-lethal suicide attempt. In the 2 years prior to referral, Cindy had been hospitalized at least 10 times, one lasting 6 months for psychiatric treatment of suicidal ideation, had engaged in numerous instances of parasuicidal behavior, including at least 10 instances of drinking Clorox, bleach, multiple dip cuts and burns, and had 3 medically severe or nearly lethal suicide attempts, including cutting an artery in her neck. Until age 27, Cindy was able to function well in work and school settings, and her marriage was reasonably satisfactory to both partners. Although the husband complained of Cindy's excessive anger, when Cindy was in the second year of medical school, a classmate she knew only slightly committed suicide. Cindy stated that when she heard about the suicide, she immediately decided she wanted to kill herself also, but had very little insight into what about the situation actually elicited the inclination to kill herself. Within weeks, she left medical school and became severely depressed and suicidal. Although Cindy presented herself as a person with few psychological problems before the classmate's suicide, further questioning revealed a history of severe anorexia nervosa, bulimia nervosa, and alcohol and prescription medication abuse, originating at the age of 14 years old. Over the course, not 14 years old, originating at the age of 14 years. Over the course of therapy, a consistent pattern associated with self-harm became apparent. The chain of events would often begin with an interpersonal encounter, almost always with her husband, which culminated in her feeling threatened, criticized, or unloved. These feelings would often be followed by urges either of self-mutilate or kill herself, depending somewhat on her feelings of hopelessness, anger, and sadness. Decisions to self-mutilate and or commit suicide were often accompanied by the thought, "I'll show you." At other times, hopelessness and the desire to end the pain permanently seemed predominant. Following the conscious decision of self-mutilate or attempt suicide, Cindy would then immediately dissociate and at some later point cut or burn herself, usually while in a state of automatic pilot. Consequently, Cindy often had difficulty remembering the specifics of the actual facts. At one point, Cindy burned her leg so badly and then injected it with dirt to convince the doctor that he should give her more attention. That reconstructive surgery was required. Personality disorders are defined by long-standing and pervasive ways of being that cause distress and impairment through their influence on forming and sustaining a positive self-identity and constructive relationships. Many people with personality disorders experience comorbid, episodic conditions such as depressive and anxiety disorders as well as other personality disorders. In DSM-5, personality disorders are classified in 3 clusters, reflecting the idea that these disorders are characterized by odd or eccentric behavior. Cluster A, dramatic, emotional, or erratic behavior. Cluster B, or anxious or fearful behavior. Cluster C. An alternative DSM-5 model was proposed that includes only 6 personality disorders. The alternative model also includes a dimensional system for evaluating personality trait domains and more specific personality facets. The alternative model is placed in the appendix of the DSM-5 and is found in Appendix B of this reviewer. 5-factor model, a personality theory that isolates 5 major dimensions of personality: neuroticism, extraversion, openness to experience, agreeableness, and conscientiousness. Personality disorder. A group of disorders involving long-standing, inflexible, and maladaptive personality traits that impair social and occupational functioning. Personality trait domains. 5 personality domains, not domains in dimensions, included in the appendix of DSM-5 to help supplemental diagnosis of personality disorders. Negative affectivity, detachment, antagonism, disinhibition, and psychoticism. Personality trait facets. 25 specific personality dimensions included in the appendix of DSM-5 to provide greater detail on the personality trait domains. Odd or eccentric cluster. The odd or eccentric cluster of personality disorders cluster A includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. People with paranoid personality disorder are suspicious of others. People with schizoid personality disorder are socially aloof, and people with schizotypal personality disorder are eccentric in their thoughts and behavior. Genetic studies indicate the schizotypal personality disorder and schizophrenia are related. Cluster A. Personality disorders appear to be highly heritable. Paranoid personality disorder, a personality disorder defined by expectation of mistreatment at the hands of others, suspicion, secretiveness, jealousy, argumentativeness, unwillingness to accept blame, and cold and unemotional affect. Schizoid personality disorder, a personality disorder defined by emotional aloofness, indifference to the praise, criticism, and feelings of others, maintenance of few, if any, close friendships, and solitary interest. Schizotypal personality disorder defined by eccentricity, oddities of thought and perception, magical thinking, illusions, depersonalization, derealization, digressive speech involving over elaborations, and social isolation. Under stress, behavior may appear psychotic. Dramatic or erratic cluster. The dramatic or erratic cluster, cluster B, includes antisocial personality disorder, APD, borderline personality disorder, BPD, histrionic personality disorder, and narcissistic personality disorder. The key features of APD include violation of rules and the disregard for others' feelings and social norms. Psychopathy is related to antisocial personality disorder but is not defined in the DSM. Psychopathy criteria focus on internal experiences as well as observable behavior. Borderline personality disorder is defined by intense emotionality, unstable sense of identity, and impulsivity. Histrionic personality disorder is characterized by exaggerated emotional displays. Narcissistic personality disorder is characterized by highly inflated self-esteem but a deep need for admiration. Antisocial personality disorder defined by the absence of concern for others' feelings or social norms and a pervasive pattern of rule breaking. Borderline personality disorder defined by impulsiveness and unpredictability, an uncertain self-image, intense and unstable social relationships, and extreme swings of moods. Or not swings of moods, swings of mood. Histrionic personality disorder. A personality disorder defined by overly dramatic behavior, emotional excess, and sexually provocative behavior. Narcissistic personality disorder. Personality disorder defined by extreme selfishness and self-centeredness, a grandiose view of one's uniqueness, achievements, and talents, an insatiable craving for admiration and approval from others, willingness to exploit others to achieve goals, and expectation of much more from others than one is willing to give in return. Psychopathy, a personality syndrome related to antisocial personality disorder but defined by an absence of emotion, impulsivity, manipulativeness, and irresponsibility. When carefully measured, APD and psychopathy are both highly irritable. Beyond genes, family environment, and poverty play a role in the development of this disorder. People with psychopathy have little anxiety. Their callous treatment of others might also be linked to their lack of empathy. People with psychopathy are deficient in using negative feedback when pursuing reward. That is, they behave impulsively. This lack of anxiety and empathy, as well as their impulsivity, may drive misconduct without regret. There is evidence that BPD is inherited. Biological task not biological task, biological risk factors seem particularly related to emotional dysregulation and impulsivity. Consistent with a greater emotionality, people with BPD demonstrate increased activity of the amygdala and have high rates of mood disorders among relatives. Consistent with the impulsivity, research indicates diminished activity of the prefrontal cortex among people with BPD and high rates of disorders involving impulsivity among first-degree relatives. People with BPD report elevated rates of abuse. Linehan's model builds on the high rates of abuse and parental invalidation reported by people with BPD, and also emphasizes the biological diathesis for emotional dysregulation. Researchers know relatively little about the roots of histrionic personality disorder. This personality disorder is believed to be related to poor parenting. According to the self-psychology theory of narcissistic personality disorder, parents who are cold and focused on their own worth fail to help the child develop a stable sense of self-worth. Social cognitive theory proposes that the behavior of the person with narcissistic personality disorder is shaped by the goal of maintaining specialness and belief that the purpose of interpersonal interactions is to bolster self-esteem. Anxious or fearful cluster. The anxious or fearful cluster includes avoidant, dependent, and obsessive-compulsive personality disorders. The major symptom of avoidant personality disorder is fear of rejection or criticism, of dependent personality disorder, excessive reliance on others, and of obsessive-compulsive personality disorder, a perfectionistic, detail-oriented style. Avoidant personality disorder is modestly heritable, but estimates of heritability vary for dependent and obsessive-compulsive personality disorders. Social theories of etiology for the anxious fearful cluster focus on parenting. Avoidant personality disorder might result from the transmission of fear from parent to child via modeling. Dependent personality might be caused by disruptions of the parent-child relationship and overprotectiveness that lead the person to fear losing other relationships in adulthood. Avoidant personality disorder. Personality disorder defined by aloofness and extreme sensitivity to potential rejection despite an intense desire for affiliation and affection. Dependent personality disorder. A personality disorder in which people are overly concerned about maintaining relationships. People with this disorder often allow others to make decisions for them and are reticent to make demands that could challenge relationships. Obsessive-compulsive personality disorder. Personality disorder defined by inordinate difficulty making decisions, hyper-concern with details and efficiency, and poor relations with others due to demands that things be done just so, as well as the person's unduly conventional, serious, formal, and stingy emotions. Treatment of personality disorders. Personality disorders are usually comorbid with other disorders such as depression and anxiety disorders, and they predict poorer outcomes for these disorders. Psychodynamics, cognitive behavioral, and pharmacological treatments are all used for personality disorders. Research on day treatment programs is promising. Relatively little research has been conducted regarding the treatment of personality disorders, and the gap in knowledge is particularly severe for some personality disorders. Treatment of schizotypal personality disorder is parallel with the treatment of schizophrenia. Antipsychotic medication and sometimes antidepressant medication can be helpful. Treatment of avoidant personality disorder is parallel with the treatment of social anxiety disorder. Antidepressants and cognitive behavioral treatment can be helpful. Psychopathy, formerly considered virtually untreatable, might respond to long-term psychoanalytic treatment. Some promising evidence is emerging for the utility of dialectical behavior therapy, mentalization-based therapy, and schema-focused therapy for borderline personality disorder. Dialectical behavior therapy, a therapeutic approach to borderline personality disorder that combines client-centered empathy and acceptance with behavioral problem solving, social skills, training, and limit setting. Mentalization-based therapy, a structured form of psychodynamic therapy developed for borderline personality disorder in which the person is encouraged to focus on his or her emotions and relationships. Schema-focused cognitive therapy enriches traditional cognitive therapy with a broader focus on how early childhood antecedents and parenting shape current cognitive patterns. In schema-focused therapy, the therapist and the patient work to identify the maladaptive assumptions, schema, that a client holds about relationships from his or her early experiences, page 488. Additional notes in personality disorders. Therapies for borderline personality disorders or BPD, dialectical behavioral therapy. Clients are taught to monitor self-disparaging thoughts and black or white evaluations of people with BPD and to challenge these thoughts and evaluations. Also involves learning appropriate assertiveness, skills to use in close relationships, so needs and feelings can be expressed. In a mature manner, clients learn how to control their impulsive behaviors by monitoring situations that most likely lead to such behavior and learning alternative ways to handle the situations. Therapy benefits reduce depression, anxiety, self-mutilating behaviors, and increases interpersonal functioning. Cognitive therapy, systems training for emotional predictability and problem solving, STE, PPS, group intervention for people with BPD, combines cognitive techniques, challenging irrational and maladaptive cognitions and behavioral techniques, addressing self-management and problem solving. STE, PPS clients show greater improvement in negative affect, impulsivity, and functioning than clients receiving usual therapy. In other words, support plus medication. Cognitive behavioral therapy, CBT for BPD, focuses on challenging patients' maladaptive core beliefs and teaching them more adaptive ways to function in daily life. Result: significant reductions in hospitalization and suicide attempts, greater improvements in mood. Psychodynamic therapies for BPD, transference focused therapy, uses the relationship between client and therapist to help patients to develop a healthier and more realistic understanding of themselves and their interpersonal relationships, has resulted in reductions in suicidality, impulsivity, aggression, and anger. Mentalization-focused treatment, based on the theory that people with BPD have a fundamental difficulty understanding their own mental states and that of others because of traumatic experiences in childhood and poor attachment to caregivers, provides patients with validation and support. It attempts to help patients appreciate alternatives to their own subjective sense of self and others by using the relationship between the patient and the therapist and the patient and others to illustrate those alternatives. Sample test questions for personality disorders. Number 1. A 28-year-old law student is admitted to the hospital for gallbladder problems. He is stubborn, rigid, and expects staff to adhere to his exact way of doing things. He refuses to stop working on school papers. He reports that his girlfriend has threatened to leave him unless he changes his inflexible ways and throws out some of a large collection of useless junk. Which diagnosis seems more appropriate? A. Antisocial. B. Avoidant. C. Histrionic. D. Obsessive-compulsive. E. Schizotypal. 2. You expect the patient in question 1 may act out in which of the following ways when under stress in the hospital? A. Strange behavior may put off strangers. B. Sees hospitalization as a threat to his control. C. Can be charming but in a manipulative way, resists rules. D. Uses splitting, possibly dividing the staff who might take sides. E. Likely to be cooperative and do well with the attention. 3. Patients with which of the following personality disorders are most likely to handle the stress of hospitalization relatively well? A. Antisocial. B. Avoidant. C. Borderline. D. Dependent. E. Schizotypal. 4. Persons who experience others as either all good or all bad and cannot experience an ambivalent relationship are exhibiting which of the following mechanisms? A. Denial. B. Identification. C. Projection. D. Regression. E. Splitting. 5. A 35-year-old man requests psychotherapeutic intervention for problems with reacting angrily to his co-workers. The patient reports persistent fear that he will lose his job due to a system that is out to get me. He reports distrust of others and it's either me or them philosophy. Which diagnosis appears most appropriate? A. Antisocial. B. Avoidant. C. Narcissistic. D. Obsessive compulsive. E. Paranoid. 6. A psychological mechanism often seen in antisocial PD is A. Externalization of blame. B. Sublimation. C. Internalization of blame. D. Splitting. E. Magical thinking. 7. In an interview, which scenario would suggest a diagnosis of histrionic PD? A. Inappropriate laughing when talking of a breakup. B. Speaking impressionistically and dramatically shifting between expressions of grief and happiness. C. Being tearful and stating that he or she couldn't eat, sleep, or work since the spouse left. D. Concerned that the spouse had been taken over by an evil spirit. E. Talking about aliens having exchanged the spouse for an imposter. 8. Which of the following best describes narcissistic PD? A. The prevalence is 10% of the general population. B. They are rarely very successful in their work. C. Feelings of insecurity are masked by arrogance. D. It is more preventive in women than in men. E. Frequent work with humanitarian groups. Changes from DSM-IV-TR to DSM-5 personality disorders. The categorical classification system for personality disorders is unchanged. The 10 personality disorders in DSM-IV remain paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder, antisocial personality disorder, borderline personality disorder, histrionic personality disorder, narcissistic personality disorder, avoidant personality disorder, dependent personality disorder, and obsessive-compulsive personality disorder. The multi-axial system has been dropped in favor of a system evaluating psychosocial and contextual factors and uses a new trait-specific diagnostic method.